Good morning. There are about 300 surgical cases done every year, and about 100 million develop hypotension during general anesthesia induction. So the question is there a way to predict hypotension if it will happen? I will be presenting a research entitled The Predictive Value of Baseline Pulse Oximeter Perfusion Index on the Incidence of Hypotension During Balanced General Anesthesia Induction. So what is perfusion index? The signal from the pulse oximeter waveform or the plethysmograph is derived from the AC or variable or pulsatile component and the DC or constant or non-pulsatile components of tissue blood flow. Perfusion index can be computed by dividing the AC to the DC and multiplied by 100. Perfusion index is expressed in percent and ranges from 0.2 to 20%. Perfusion index has been used as an indicator of systemic vascular resistance. Therefore, it's a continuous, the indirect, and non-invasive measure of peripheral perfusion. So, in general, a high perfusion index can be interpreted as having good perfusion or vasodilation or having a good pulsatile flow, whereas a low perfusion index can be interpreted as having poor perfusion or vasoconstriction or poor pulsatile flow. Studies have shown that perfusion index is useful in monitoring effectiveness of regional anesthesia, depth of general anesthesia, a successful epidural placement, and hemodynamic status of critically ill patients. A 2017 study published in the Indian Journal of Anesthesiology concluded that baseline perfusion index could predict hypotension following propofol induction. In their study, they used the Philips IntelliVue MP40 anesthesia monitor to measure perfusion index. We used the Innovo fingertip pulse oximeter with plethysmograph and perfusion index from Stafford, Texas, for reasons of accessibility and affordability. So we hypothesized that baseline perfusion index taken from portable pulse oximeters can predict hypotension during balanced general anesthesia induction. So the aim of our study is to determine if baseline perfusion index measurement can predict hypotension during induction of GA, and our specific objectives were as follows. So 35 patients aged 18 to 65 years old belonging to the ASA classification 1 to 2 and will undergo an elective surgery under general anesthesia were enrolled in this study after obtaining a written and informed consent. My exclusion criteria were as follows. Upon reception in the operating room, baseline values were recorded. Pre-oxygenation was done, followed by induction of general anesthesia, and 5 minutes after giving the neuromuscular blocker, the trachea was intubated. All parameters were simultaneously recorded every minute for 15 minutes. So hypotension was not observed in the first 5 minutes, but was present in 11.4% of patients in the 10th minute and 5.7% in the 15th minute. Point by serial correlation analysis revealed that baseline perfusion index showed very low to low, negative to positive, and insignificant correlation with hypotension, whether using systolic blood pressure or MAP criterion. Interestingly, plotting perfusion index against other parameters showed an overall positive and significant correlation between perfusion index and systolic blood pressure, diastolic blood pressure, and MAP respectively. The area under the ROC curve showed an inconclusive evidence on the usefulness of perfusion index to predict hypotension for this sample of patients. As of this writing, there are no available literature comparing perfusion index readings of affordable finger-clipped pulse oximeters against the readings of more sophisticated operating room monitors. Our explanations are all based on theoretical facts from literature. We don't have direct physical evidence of the mechanisms proposed in this study. So in conclusion, our study showed inconclusive evidence that baseline perfusion index measured using the Innovo IntelliVue fingertip pulse oximeter can be used to predict hypotension during general anesthesia induction. So the pulse oximeter perfusion index can be used as a non-invasive method of measuring hemodynamics. However, we cannot propose the use of inexpensive pulse oximeters as a tool to predict hypotension during induction of general anesthesia. A future comparison study of perfusion index readings between affordable pulse oximeters and more sophisticated operating room monitors can be undertaken. Thank you.
Okay, you made a good, very good presentation, but I wanted to know why you mentioned that this study shows an inconclusive evidence. Is it because the number of your population is not enough to make a conclusion?
Upon analysis of our results, we did not find any correlation between the baseline perfusion index and their baseline systolic and the baseline blood pressure and the incidence of hypotension during induction of general anesthesia. So there, as is, making an ROC curve is already futile because there was no correlation that was present. So if we make an AUC ROC curve, we cannot actually generate a cutoff value already. Yeah,
Good morning.
Good morning, ma'am.
I just want to clarify. I forgot about my biostatistics, but I think you use ROC when you make a study on prognosis. If you want to make a correlation on variables, the statistical tool would be the Spearman's, the correlation coefficient. So AUC is for prognostic. You just review on it, okay?
Yes, ma'am.
Okay. So I have read the limitation that you stated on your paper. So you decided on using the portable or the fingertip pulse ox.
Yes, ma'am.
Okay. What is the sensitivity and specificity of the tool?
That was part of my limitations, man. As of now, there are still no present study comparing the measurement from those affordable pulse oximeters, comparing it with other sophisticated monitors, for example, from Massimo, from Philips, or and other monitors that are more sophisticated and more expensive.
The reason why I asked that question is I would have suggested to you that you should have done that as the first part of your paper. You know, knowing the sensitivity and specificity of the tool that you're going to use on your present paper.
Yes, ma'am.
So it would have been better if you have done a paper on comparing a gold standard versus the portable instead of this. Kasi the results
Yes, ma'am.
parang inconclusive. Usually I tell the trainees na, you know, if you're gonna make an effort on doing a paper, make sure that whatever it is that you're get the conclusion, it would be, you know, useful for practice.
Yeah.
So I would suggest you suggest it to your junior to make a paper. Parang ito yung dapat yung prologue ng paper mo. Okay, and then last question. So you're talking about the predictive value. So I was looking for the